I hope you all can hear me so this is William Callow, leader of implementation science for the Penn State CTSI. I'm so happy to be here. I want to just say thank you so much for SSRI and Deb for hosting us. This is the very first implementation science seminar that we co-host SSRI and CTSI. And it's going to be the first one of many, especially as we want to do more work at the intersection of let me see if this is that they can hear me. Yeah, good. That this is many of the one that we can do hopefully every year to continue bringing implementation science, bringing together science, social science, health policy, health services research. So I want to start introducing our amazing speaker of the day. She is Dr. Erika Crable, assistant professor at UCSD. She has expertise in health policy, health services research, and implementation science. She investigated the roles of policy and politics in achieving health equity outcomes, including testing, dissemination, and implementation strategies aimed at improving how research is communicated to policy actors and increases access to evidence-based substance use treatment for safety net and criminal legal involved populations. Dr. Crable is co-director of the Health Services Research and Health Policy Research Program at UCSD, an investigator at the Dissemination Implementation Science Center. She is an alumni of the NIMH, NIDA-funded Implementation Research Institute Fellowship, and NIDA-funded Lifespan Brown University Criminal Justice Research Training Program. She previously worked as a health policy consultant to the Centers for Medicare and Medicaid Services, Substance Abuse Mental Health Services Administration, or SAMHSA, Assistant Secretary of Health and Human Services for Planning and Evaluation, among other federal and state entities. On top of that, she's a tremendous teacher and mentor. She developed one of the first implementation science courses at Boston University, where she did her PhD. And she also have been working a lot developing teaching opportunities and mentoring for students at UCSD. She's very active in national, international conferences. You can find her every year at the DNI annual conference and also at some other big lectures, including the master lecture at UK with some big institutions over there. I just want to say that the first portion of this seminar is hybrid. We're going to be having people here in person and Zoom. She will be able just to say how the people in Zoom will be just asking questions with the presentation at the very end, whatever she prefers. And then we will pause at 2 p.m. and we will have an in-person workshop for the people here in the room. So Dr. Crable, please. Welcome to Penn State.
Thank you. What an introduction. Well, first I want to say that lots of great people helped develop some of those programs that I was either a part of or contributor to. So I don't want to take all the credit. I want to make that clear. So yeah, let's talk about engaging in implementation science. And I wanted to give you this like nice soothing water background so that you don't feel like anxious about this, right? A lot of people are saying implementation science lately. And what do we mean by that? That sounds scary. You're telling me I need more credentials, a new degree. No, the answer is no up front. That's the spoiler. So let's just have a nice fun conversation about D&I science. And yeah, happy to take questions and have a conversation. I don't know how that will work for the folks on Zoom. Hopefully I can see chats, but we'll figure that out as it comes. So what do you need to know about D&I science or implementation science really specifically? Okay, so the goal for today, again, I'm not going to give you a whole lecture on implementation science. I want you to just gain a new tool in your toolkit, a new perspective. So something about me is that I am a competitive sailor. So I want to give you an analogy. Just go with me on this. Sometimes we look at, sailboats in a race and we think, wow, that's really beautiful, sort of this top image here. And we think, well, that looks really nice. But at the same time, like, who's in the lead? Who's losing? Like, what are the rules? What's the course? We don't know. And that's how we might feel about implementation science. And then we start digging into it to try and learn it ourselves. And we might feel more like this bottom left corner, like the person underwater, seeing other people have a good time, and seeing other people seeming to get it, and we're drowning. So I don't want to go there either. The ideal spot is this bottom right, where we're in control, we're using it in a way that's useful for us, we're having a good time. So that's kind of the goal for today. Usual acknowledgements. I'm grateful to be funded by NIDA on a variety of different projects, as well as the Research Council of Norway. And just to note that my slides are not 508 compliant. So if you do need an alternative version of the information, please reach out to me. Okay, so our agenda for this conversation is why dissemination and implementation science matters to your work specifically. What is it? Can you just tell me that part, right? And what are the basic elements you need to know? And then I want to leave you with some resources locally and nationally as well. And we'll have a Q&A throughout and at the end. And then if you're here in person, we'll do a build your own D&I into your work type activity. So a couple of things about why it matters. This graph should terrify you because it's A, really ugly, and B, really scary. So I want to point out two lines on this graph. The red and the blue represent preventable and treatable mortality in the US, and the other countries are other OECD countries that you can compare the US to. So in the US, we spend more on healthcare than any other country. In fact, and that's as a percent of our gross domestic product, just to be clear. And we're nearly twice as high as the next highest spender, which is Germany. So, you know, if we think about our spending, that's Medicaid, Children's Health Insurance Program, Medicare, commercial employer-sponsored insurance, as well as out-of-pocket costs, and as well as the VA TRICARE. So if we're looking at this and we're thinking, well, we spend so much, aren't we getting really good value for all that money we invest in our healthcare system? The answer is absolutely not. Because if we look at preventable mortality and treatable mortality, we're thinking about stuff that could be prevented through effective public health and primary prevention, right, to reduce the onset of disease or other types of injuries. And so we have a lot of science about what are effective public health and primary care type preventative services, but why, and we spend a lot of money. So the next question we should be asking ourselves is, what are we going to do about this problem so that our graph doesn't look like this anymore? We're sort of more toward the bottom, right? So I want to talk about what we can do and maybe how we got here. We have a lot of gaps. We have a gap that we like to talk about in implementation science called the research to clinical practice gap, right? What we know works doesn't translate to the bedside. We have a research to policy gap. What we know works isn't implemented in evidence-informed policies. And all of this culminates sort of in a general research to action problem. And all of this promote health disparities. So here are a couple of examples to make this a little more concrete, because I like concrete examples. When we have these research to practice or policy gaps, we have a prevalence of low value healthcare services, right? So nearly 30% of care provided in the US constitutes unnecessary services. You can think of these as unnecessary imaging, scans, that type of stuff. And so we're wasting a lot of that money that we're spending, right? And we're seeing that ugly chart before. But we also have really negative health outcomes that occur when we have policies or programs that aren't evidence informed. So I think a lot about how to improve access to substance use treatment, which means I think about the gap we have there. So when you see substance use treatment care settings that don't offer evidence-based services, we see individuals living with substance use disorders downplay their use, downplay the pain that they might be living in, they delay care seeking, and they can disengage from care altogether. So that's an example of where we're not taking what we know works, putting it into whether it's big P federal policies or little p organizational policies that govern how a hospital system or a healthcare system operates, or your local provider's office. And we see these negative health outcomes. So why is this kind of happening? You know, I think there are a ton of reasons. We have pretty weak dissemination plans as researchers. We have like that as a paragraph in our grant applications most of the time. And it's sort of like, I'll present at a conference, I'll write some journal articles, and I'll probably put them behind a paywall unless I budget in a couple $1,000s into my grant to make them open access. And then that'll reach like 10 researchers maybe. Like who's it reaching, right? Like if we're lucky, we get better metrics than that, but still like, are the people who need that information getting it? So we have pretty poor dissemination plans. And when we do write our outcomes up. Sometimes they're really unclear because we write them in academic jargon, or we study outcomes that are interesting to us as researchers, but maybe they're misaligned with the policy actors or decision maker needs that you have in your local health system. People who need your findings, especially non-academic researchers, they have really varying levels of capacity to look for that kind of evidence effectively, to interpret it and use research in their day-to-day work. They also might have trust issues with how the research was done, or they could just have competing demands, right? So it's not evidence on your one thing isn't the only thing they're thinking about in a day. They're thinking about 10 different things. And they might also ask you, you did a really beautiful RCT. They're not going to totally understand the ins and outs of a randomized control trial, but they've heard that's the gold standard. But then they immediately wonder, well, how does that actually apply in the real world where my population or my setting looks really different? So I'd argue we have a lot of gaps, most of them of our own doing as researchers. And so I think the research to action gap is actually a D&I researcher problem to solve. And if we make it our problem to solve, then we can be part of the solution, right? And not just take the blame. But if we say it's not on us, it's on the people making decisions in health systems or the policymakers, then all of a sudden we take ourselves out of the solution. So I'd rather be on the side of bettering it. I'm also curious how much of that, we always talk about a 17-year gap between evidence and routine practice. And that's sort of the motivation for implementation science. I'm wondering how much of that is our fault and how much of it is the fault of us not communicating this to policy in an important way. So if you're sitting there thinking, I'm an effectiveness or efficacy researcher, I don't know how this applies to me, it's not really my thing, I will say that's totally fair. The goal isn't to make you become an implementation scientist or someone who uses implementation science in all of their work. The idea is to think about what are things I need to get my research from, these earlier spots in basic translational research all the way over to T4, translation to the community. That's what implementation science is all about. And it might not be your thing, but a D&I researcher might be the collaborator you've been missing. So then your next question might be, well, where do I even go? Like, who funds this kind of stuff? It doesn't look familiar to the RFAs or RFPs that I respond to. Increasingly, people are really interested in this. There's a really good article in JAMA that came out earlier last year about different places people get funding for this. I highlighted here the National Institute on Mental Health, the National Institute on Drug Abuse, both have implementation science, and you'll see words like translation into real world settings, things like that, scale up, adoption, those are kind of your keywords. You'll see them in their strategic plans. I'll also on an NIH note that this particular part right here, the dissemination and implementation research in health, is a funding opportunity that is available across 22 participating NIH institutes. So mental health, substance use might not be your thing, but there's 20 other institutes who are also funding that type of work within the NIH. And then within the National Science Foundation, I know a lot of people here have funding from them. There's a current supplement funding opportunity for translational implementation science work, and there are several others. This is just sort of a sampling. So let's move on to what is implementation science. Like, what am I even talking about for those who might be a little less familiar or less sure of their knowledge on this topic? And I'm going to go back to my saline sort of an analogy here, right? This feels like a really kind of hard question. And so I put a really difficult knot to tie on here, right? This is a really important knot. This helps you reef your sail in a storm and have better control over your boat. So you definitely need to know how to do it, but it's a complicated answer. Right, so what is implementation science? The NIH gives us the really complicated, long definition, saying it's the scientific study of the use of strategies to adopt and to integrate evidence-based healthcare interventions to improve individual outcomes and benefit population health. That's huge. Let's break that one down for you. What is implementation science simplified? And I am not going to take credit for this one. This is, if you've ever had the pleasure of hearing Jeff Kieran speak, he has a really great slide on this and a really wonderful short article that I've cited here. He breaks it down and says, what is it simplified or made too easy in his words? It's about your favorite intervention or practice, the thing. And traditional research or effectiveness research would say, does that thing work? Once we know that thing works, then you're ready for implementation research. And it basically boils down to, we could have the long definition from the NIH, but it basically boils down to how to best help people do the thing that we know works. The implementation strategies are the actions that we take to make that thing happen. And the outcomes are not about how effective the thing is, because remember, we already know that. And now we're looking at how much or how well did people do the thing wherever you wanted it implemented. I keep saying dissemination science, so here's another complicated rope or line we might call it. And we would say that's the scientific study of the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. We all lived through COVID. We know that we did a very bad job on dissemination science during that experience. So a lot to learn here. But if we break it down in similar language and simplify it, your favorite evidence-based practice is still the thing. Dissemination research is just how to best communicate that thing. And what are the actions we take to communicate that thing? And how much or how well was it communicated or shared with the right population? So here's some examples. Again, I'm not going to go into them. And these are just a few examples of projects I've worked on. This is not all of it, right? These are just the projects that I feel comfortable with you asking me questions about, because I don't want to talk about other people's work. So some of the questions we ask in implementation science could be like, a very basic one that a lot of people start out with is, what are the barriers of facilitators to implementing some evidence-based practice? How do the stakeholders implement an evidence-based practice? And which implementation strategies are optimally able to support uptake of that evidence-based thing? So I've studied that at a policy level, looking at how you take a really well-crafted policy and translate it into brick and mortar services in doctors' offices. We could look at how in a probation office, a great colleague of mine, Tanya Van Dens, she led this project where we looked at how probation officers think about implementing specialty mental health probation models in their complex systems. And if we move over to the dissemination side, right, all about communicating, we start asking different questions. How do stakeholders use research to inform their decisions? That's the subject of this tailoring dissemination strategies project I lead right now. And what dissemination strategies optimally spread knowledge of an evidence-based practice? So that's what I'm hoping to learn in that project. So those are just some examples. So how are we feeling with definitions and sort of wrapping our head around what dissemination and implementation science is? Good, bad, neutral?
Great, ready to go.
Okay, love it. That's the answer and confirmation I needed. Thank you. Okay, so what are the basic elements to doing this? Now that I've convinced you, we've got a research to action gap. We have a field of study that's going to help us address it. We think it's our problem to solve. So how do we go about doing it? So a couple steps. Step one, what's the care or quality gap? This is pretty basic. It comes from, and I like how this is laid out. Enola Proctor was at WashU for a very long time, a real powerhouse in D&I science. And she always asks this question: what's the care quality gap that keeps you up at night? What undesirable health outcome might you want to change? And I would argue that don't just think about a health outcome, think about D&I science as a way to do work in other fields for outcomes you want to change as well. And then I start asking myself, well, once I know an outcome that I want to change, is there an underused or somehow inaccessible evidence-based or evidence-informed thing that I can use to help? And once I figure that out, I say, well, who needs to do this thing that's not being done? Do I need to intervene at a real macro policy level? That's usually where I do my work. But most implementation science is done at the provider team level or provider organization level. So think about the levels that matter to your work. And then ask yourself, you know, if I'm thinking about this with how I traditionally write my grants, is this my innovation? No, the innovation is still the thing that you want to deal with, but the care quality gap is really part of your public health significance, what you're trying to change. So Enola Proctor also gives us this really great model. for just thinking through how all of the components of an implementation science study connect. So we've thought about what our thing is, right? Whatever our gap is that we care about, that's usually a service or a client outcome, right? Like too much preventable mortality, right? In a given thing, hang your hat on some disease or some clinical practice. And then that tells us what our evidence-based thing is to implement, right? So if I see too many high rates of preventable cancer, then we look at cancer screening as the underused thing, right? That could be a connection. And we start thinking about, well, what intervention strategies might we need to go to what level? Policy level, the systems level, the organizational group or individual level. And we just start thinking about that connection between all three of those. But we're sort of start to get stumped because we can't come up with everything that we need to study. You know, we need some guidance. And that's where a useful theory model or framework comes in as a guiding roadmap for your work. Just quick show of hands of folks in the room. How many people hear theory model or framework and sort of want to glaze over or just not be part of that conversation? Okay, at least one person's being honest. I like that. Yeah, because they're kind of like a lot, you know? So let's break it down and make it a little bit easier. So I think of theory models and frameworks as really practical tools. And I was talking with a very excellent group of doctoral students this afternoon about this exact thing, right? So why do we need theories, models, or frameworks? A, if I give you the really practical answer, they're expected in a grant. So make sure you put one in, but then really use it, right? Use it as a roadmap to say, where am I going? What variables might I need to study? What relationships might I need to test or interactions might I need to look for in my data that informs methods you use and the data you collect and the outcomes you choose to measure. And it can also really help you refine your aims over time and think about the stakeholders that need to be involved in this. But I would also argue that I really love testing theories, models, and frameworks because they should be tools for us. So testing them can really help us advance science about knowing what does work and doesn't work and where those relationships truly exist. So how do you even pick one? In implementation science, we have a really big desire to create lots of theories, models, and frameworks, up to, I think, in the hundreds at this point. But you've got a couple of choices to make. You think about a theory, model, or framework by deciding what you need from it, because again, it's a tool. So if you need something to describe the process of translating research into action, you pick a process-focused framework, for example. If you want to understand barriers, facilitators, or determinants, then you pick a determinant-focused framework. And if you just want to look at evaluation, you can think about an evaluation-focused framework or model. So think about the process that you, or the issue that you need, and then pick a framework or theory or model that maps to it and does what you need it to do. So if you're not sure where to start, there's this interactive web tool that I linked here, and it basically helps you walk through the steps of searching the D&I focused theories, models, and frameworks that are available and how to use them in your work. And then also, Per Nelson has this great paper, Making Sense of Implementation Theories, Models, and Frameworks, that I really highly recommend to people who are new to the field. So you get a sense of why our theories, models, and frameworks are a little bit different than the ones that you might see traditionally in your social science fields. So let's just take one example, and I picked EPIS because I use it in a couple of my projects right now, and it's a super flexible framework that does both process and determinant work for you. So it holds two jobs, which I really like. But pick a framework that matches your question. Don't pick one and keep using it for your whole career. That's not good science, right? Like, pick a theory, model, or framework that does the job you need it to do and answers the questions you're asking. So here's an example of just using EPIS just to talk us through one, right? I can think about specifying what my inner context is, usually where I'm intervening. My outer context, that sort of like sends influences or determinants, barriers, facilitators toward my inner context usually. Sometimes it acts as a call and response, and you get it both ways. And every theory, model, or framework in D&I pretty much has this. Sometimes they call it external and internal setting. but everybody's got an inner and outer setting essentially. And then I like this one because it has bridging factors, which basically just says, how do I promote alignment between the two? That might be an implementation or a dissemination strategy, but it could also be other things that you can leverage, like data sharing processes or key intermediaries who are thinking about inner and outer contexts and able to bring them together. And you might want to leverage that as one of your implementation strategies. And then innovation factors, again, sometimes that's intervention characteristics. That's just your thing, right? Your evidence-based thing. So hopefully just sort of seeing this breaks it down to where they're all kind of similar to ones you've seen before at least. So once we've chosen a theory model or framework and it's helped us think about what constructs we might want to measure, what relationships we might want to look for, what outcomes we might want to assess, we can ask ourselves, well, how do I get there? I need an implementation strategy to get me there. So this is, again, just the action to help people do the thing. And you want to leverage those determinants, those barriers and facilitators that you identified in your guiding framework, theory, or model. And you want to be very specific. What do I mean by inner and outer context? Because that tells you about where you need to align your implementation strategies at. It might be that you need multi-level strategies working in different places at the same time. So if you wanted to affect change in one clinic of a hospital, you might not only need to intervene with that clinic, you might also need to intervene at the hospital level too, right? Like higher level leadership as well. So that's just an example of, you might think about it as multi-level when you start designing your implementation strategy or strategies to get people to do the thing. And then something that I don't see a ton of, but there is a growing movement toward, is understanding why you chose that implementation strategy. Why do you think it's going to work? That's like really important, right? Because we need to have justification. We can think about that as the underlying mechanism, why we think it'll work, what's there that this is acting on to achieve the desired outcome. So again, implementation strategy in this case is what you're testing. You're not testing necessarily the effectiveness or efficacy of your evidence-based thing anymore because you already done that. The implementation strategy is what you're testing. You could randomize it, you can observe it, however you want. You're measuring the impact or assessing the impact of it. And if you still really want to measure effectiveness of the thing, that's okay. We have hybrid designs that do both, and you can absolutely do that. It's just a bigger study question. So we can start to build out our implementation science research model again by saying, okay, how does my evidence-based practice get leveraged by my implementation strategy at the right level to achieve the outcomes of interest? And notice I added finally in implementation outcomes in that first outcomes box. This is where we want to see the direct effect of that implementation strategy or set of strategies that you're using. So we've got a couple of things to measure here. I find the outcome stuff really trips people up because they're used to saying, well, I want to measure population health impact or morbidity, mortality, something like that. And those are great, you know, service and client metrics. Let's talk about implementation outcomes though. So Enola Proctor has what I like to think of as like the big 8. Acceptability, adoption, fidelity, appropriateness, feasibility, sustainment, reach, and cost. This is so understudied. That's why I put an asterisk on it. I hope people coming to implementation science want to be measuring cost of implementation strategies because that's such a needed and growing area. And if you're interested in that, there's a really cool network called Cherish that you can affiliate with, and they make pilot awards to do this kind of work. So here are some outcomes to start to think about that you might want to measure as your implementation outcomes. But again, this is not a be all end all. There are way more outcomes than this, and they need to be aligned to your questions and your population health impacts that you want to see. Okay. So we have a little bit of a choose your own adventure situation here. We can talk more about mechanics, or I can show you an example of an implementation study.
A question?
It is a question.
I vote for example, but I'm gonna speak on behalf of the group.
Okay.
I'll second it.
All right, example wins. Okay. So I'm gonna keep using language you've seen. So I'm gonna use the same framework that I already showed you once. It's gonna look a little different. So, okay, a lot of people come to implementation science from traditional health services research, yours included. And so I tried to pick an example that felt more accessible, right? We might not be ready to intervene with an implementation strategy. Maybe we just want to observe what's going on naturally in an environment. I present to you an observational policy implementation example. So remember the first question, what's our care gap? So in this example, we have seen really limited access to high quality substance use treatment in Medicaid benefits across the country. And so every state Medicaid benefit array looks different. But the one thing they have in common is traditionally not a full continuum of care to reach people at all stages of their treatment and recovery process. And so what's an evidence-based practice that fills that care gap? The American Society of Addiction Medicine developed a substance use treatment care continuum of different levels of care that they suggest should always be available and that people can move in a nonlinear way across these levels of care. But you can only do that if they're covered benefits by your insurance company, because healthcare is expensive in this country, as we already covered. Okay, so we've got a care gap and we've got an evidence-based practice. Why aren't we doing it? Well, it wasn't covered in these Medicaid benefit arrays for a really long time. And so the Medicaid contracted providers who see Medicaid members weren't offering all these services to them. And so there was an interesting policy window where the Federal Centers for Medicare and Medicaid Services basically said, we'd like all of our state Medicaid agencies to start covering these benefits. Give it a go. And so some of the states stood up and said, sure, I'll do it. And we can call those our inner context, right? So I'm putting an agency as my inner context. That's kind of a big thing. It's very macro, because again, it's a policy example. And in the outer context, I'm thinking about the Federal Centers for Medicare and Medicaid Services. You see them under leadership. I'm thinking about state legislatures, state executives like a governor who have to approve budget changes to Medicaid. But I'm also thinking about the Medicaid managed care organizations who deliver benefits to Medicaid members, right? So I start thinking through what's in my inner and outer context, like really specifying who they are, who's represented, and what their needs are. And the innovation factor is that full care continuum I mentioned. And so I start to have some questions. Well, the first question is, how did Medicaid agency staff translate really well-written policies about a full care continuum into brick and mortar services, right? It's one thing to write a policy, it's a second to translate it into care in your community. So I've got a why and a how kind of implementation phased question. And then I have how did they get managed care organizations to actually deliver the new services and bill for them? So that's more of another implementation phased question, kind of leading us towards statement. So I just started mapping this out. And if we go back to the Enola Proctor model, we could look at it this way, just to give you a second view. My EVP is under intervention strategies. That's the ASAM care continuum. And I start looking at what are the levels? Well, state Medicaid policy is a level, so policy level. Organizations at the MCOs, right? The managed care organizations, that's a level, but then also providers are another level, or even stakeholder group we could consider. So I know that they need implementation strategies at all these levels. And I'm not really interested in service or client outcomes for the purposes of this question, because I'm asking a how they did it, right? So I'm asking implementation outcomes. How did they adopt this new policy? How do they adopt new services and deliver them with fidelity? So I'm starting to think through my outcomes of interest. And then I refine my aims, describe common experiences and outcomes related to implementing national evidence-based practices within state Medicaid context, and create a taxonomy of the implementation strategies that the policymakers in these contexts actually used to promote adoption and fidelity of the evidence-based care continuums. So I just started to think through my questions. And in this particular example, it was observational. I didn't design the implementation strategies to intervene. I wanted to know what they were actually doing on their own. I looked at 3 states that had really different context to see if they did it differently. And it was a qualitative project with interviews and document review and thematic content analysis to understand what they did. So at a really high level, I found that states, I could catalog at least 29 different implementation strategies that they used across different EPIS phases, because remember, EPIS is process and determinants. Some of them are sort of obvious, and again, I've really boiled them down here for the sake of a short example. But spending a lot of time at the states developing stakeholder relationships to support buy-in across their state context, so that they wouldn't have people putting up more barriers to implementing. Then they designed financial strategies, whether it was enhanced reimbursement rates, or in the case of one state, a bunch of money to providers up front. So quote, they wouldn't be afraid to try, because a lot of Medicaid providers would be afraid to try something new because they're already operating so close to the red. And then states also did a lot of training, education, technical assistance type strategies. So I sort of cataloged them by who did it, why did they do it, what was the justification, what was the underlying mechanism they were trying to leverage to make sure they reached their adoption and fidelity outcomes. But then I also had some qualitative themes across implementation and sustainment phases. Right, so the Medicaid agencies, they adapted their own processes and rules about how their organization delivered care. And they adapted what the SUD-care continuum looked like. They adapted the thing to try and promote fit. Remember, I talked about bridging factors, looking for alignment across the settings. So they adapted the innovation plus some of their processes as bridging factors to promote more alignment and greater adoption across the state. And again, I mentioned that they had financial strategies, but ultimately in many cases, they were really inadequate financial strategies were really inadequate bridging factors to promote statewide adoption. And just the complexity of the evidence-based thing they were implementing was so different than what they typically did as business as usual, that they had limited fidelity to the actual model as written. And some of that was okay. A second study you could ask is, how much fidelity is enough fidelity? How much is, how little is too little? That's an empirical question. But again, kind of the purpose here, policy research is hard, and policy adoption at a state Medicaid level, right, our inner context, doesn't guarantee policy transfer to the outer context. So an argument for potentially different types of implementation strategies. But that's just one example of using observational methods to, again, not intervene, but document what happens with what implementation strategies are used. I want to make sure we have time for questions, so I'm going to wrap it up, but I want to give you some resources for folks who are saying, oh, I think I'm interested, but I'm not totally sure. Implementation science in our field, we absolutely love writing how-to articles. Look at some of these titles. An Introduction to Implementation Science for the Non-Specialist. Implementation Science Made Too Simple. Promises and Pitfalls in Implementation Science, so we can tell you what we think we're getting right and wrong. And then with some of my colleagues at Boston University, we created a standardized approach to evaluate implementation science proposals. And that was because we had, through our CTSI, we had pilot grant funds available for implementation science projects. And we realized that folks were having a really hard time using traditional NIH criteria to evaluate the work that was submitted for those pilot funds. And also investigators themselves weren't sure how to write implementation science into their grants. And so we created some pretty basic criteria to help us think about how to evaluate the quality of our proposals. And I use it when writing my own grants to this day, to be honest. And it's a criteria we've adopted at UCSD for our pilot funding awards. And I know some other institutions have also started adopting it, which is pretty exciting. Some of the students I met with at lunch today said, I don't know that I have time for more coursework, another certificate, or something like that in implementation science. How do I stay abreast of what's going on in it? How do I keep learning about methods in the field? I didn't have but one class in implementation science, and I just read. So some of the journals that I always take a look at the table of contents for and pick articles to read are Implementation Science. That's absolutely the flagship journal for the field. Implementation Science Communications, and Implementation Research and Practice. But again, there are so many places and venues where implementation projects are described and studies are described outside of these journals. But these are just, you're guaranteed, they're always going to have implementation science content. There's also the Society for Implementation Research Collaborative, or SIRC. And this is really great, especially for students or early career folks to join. It's a really inexpensive professional society to join. I think it might even be free for students. I can't remember. But you can sign up to have an implementation science mentor, which is what I did. And so I had a mentor at another institution who was willing to talk to me about implementation science stuff and help me navigate how to do work in this field. And now I serve as a mentor to a few mentees through CERC. We also have a conference that happens every other year, and a methods repository and a measures repository. So you have to be a member to see everything that's in it, but it co-locates really cool methods and measures for you to use in your work. Your CTSI at Penn State has an implementation science core. The people who lead it are in the room. Like, you should go check them out because they do really cool free consultations on grants, on manuscripts, and they offer seminars like this, amongst others. And I think they've got recordings of seminars. So that's a great local resource. You also have the Social Science Research Institute Implementation Science RFA pilot funding that's been given out. They're also in the room. Check them out, right? Like, maybe you have a small idea, not a small idea, but the beginning of an idea that you just need some pilot money to get kickstarted. That's a great place to look for it. And then I will just have an open door at UC San Diego where I work. We have a dissemination and implementation science center, and we always welcome people from other institutions to our seminars. We do workshops, we do consultations as well. We're not the only, game in town. Most universities that have a D&I center will do these types of seminars and workshops. So just take a look out and see what's going on around there. It's fun to learn methods from different perspectives. So with that, I will wrap it up for questions, comments, other things. And at some point we'll transition to the activity. So thanks so much for your time.
Just a reminder, there's a lot of people on Zoom. Mark,
Yes,
are there
there's stuff in the chat.
You can at any time.
You can see in the screen if there's any question. Erika, I'll throw if there's any question here from the room. I have a couple of questions, but maybe some people are timid here.
There's a question online too.
Okay, so what this
Yeah. Ana Poblacion asks if I can share the blueprint for writing implementation science that was created in partnership at BU. And I think Anna's still at BU. Yes, so that's the INSPECT criteria. It's just a clever acronym because in public health, we love acronyms. So our criteria is called INSPECT. It's just standardizing an approach for implementation science proposal evaluations, and it's published open access in the journal Implementation Science, and I'd be also very happy to share it. Karen Cielo asks, how does adoption of an evidence-based solution to a different population fit into implementation science? Oh, Karen, you must have ears in this room. We've been talking about this all morning. I love that question, right? It gets at what's evidence-based. What's evidence-based for whom, for what settings? It's always different. One of the things about randomized control trials that kind of bugs me is they're really useful to an extent, right? Like, they have their faults. They're usually enrolling really homogeneous groups of people in really super controlled settings. And so what does that tell us about how well something is going to work in the real world? I would say I like to look at evidence-informed practices and say, okay, well, we have some indication that this thing is working, this practice, policy, program, whatever. It's working for some groups. I have some scientific hunch and hypothesis that it's going to work over here in this setting for this group. In those instances, we can do what I mentioned before as a hybrid study. And there's a few types of hybrid studies, but the gist that you really need to know is I want to measure both implementation outcomes and effectiveness outcomes. So maybe I want to say, okay, how well was my implementation strategy working to get this evidence-informed thing to this new population? But then also, did the new population really benefit from that practice? Is it really evidence-based for that population as well? And you can measure those two things. So you'll have different aims, you'll have different outcomes, measuring both sides of that. And that's just a hybrid study. And then we get fancy and we say, if you do more implementation and less effectiveness, it's a certain type of hybrid. More effectiveness, less implementation outcomes, that's another type of hybrid. but all you need to know is it's a hybrid study. And if you want to go that route, there's literature on that. I think that's all of the questions from online so far.
Let me ask, there's another question here?
Hopefully it's an easy one. In that first step of the Proctor model, she talks about, or you presented here, like one of the aspects for identifying the care and the quality gaps, and you say what level?
Yeah.
What are some examples of lower levels? And what are, or could you provide an example of like one or two lower levels and what was implemented?
Yeah, I can give you a practical example from a project that that I do a little work on. So this is a project led by Greg Ahrens at UC San Diego. He's the PI of it. It's a NIDA funded project. And he does a lot of really cool multi-level work actually. And so this project, the care gap is also around retention in substance use treatment, right? So a lot of people don't go in or have a hard time staying in care. And so we did a little bit of a listening tour and talked to substance use treatment clinic providers, and at a provider level and at a supervisor level and at an executive level in a clinic. They were like, well, motivational interviewing is an evidence-based practice that we like to use. We know it helps people initiate and stay engaged in care. And we think that we know, that we're trained in motivational interviewing, but we don't do it with fidelity. So that's our underused evidence-based practice and the care gap. We want to do that better. And so in this study that Greg Ahrens leads, there's a multifaceted leadership and organizational change for implementation strategy called LOCI, which is just the acronym, Leadership for Organizational Change and Implementation. And the providers, they get MI, motivational interviewing training, as to their supervisors, but then the supervisors really become the targets of the LOCI strategy. They get training in how to create climates that support, that expect support and reward evidence-based practice use. So they'll get monthly coaching, they create leadership development plans so they can help manage up and down at the same time to create places where that motivational interviewing is used with fidelity. And so that's kind of an example of it being at multiple levels. And then we have organizational strategy meetings with the executive teams to share data. It's a very data-driven implementation strategy. So we have these organizational strategy meetings where we meet with them and say, this is what you looked like at baseline. This is how implementation of high-quality motivational interviewing is going. This is how your climate is progressing toward a climate that expects, supports, and rewards evidence-based practice use. And so that's another part of that bundle of LOCI strategy. Does that help?
Thank you very much.
Yeah, sure. Great question. And I would say that we need more multi-level implementation strategies. To think that we achieve change at one spot by one strategy focused on one population or one target group is a recipe for a lack of sustainment, right? For one group of providers, let's say, to do something, they need institutional support from the top to help them keep doing the thing after this short research period's over. And that's really the goal, right? Like, I never want to go into a setting and say, well, I'm grateful to bring 5 years of NIDA funding to this setting. Let's see how great things can look for 5 years. The goal is to have lasting change or sustainment.
You mentioned EPIs, and your example was about EPIs, which is one of those, you start talking about TMF, we have hundreds of them, but many of these are extensions of existing TMF from other fields. EPIs is one of those, and CFR is one of those developed for implementation science. Do you have some examples of theories, models, and frameworks from social science or health policy that we are adopting in implementation science, are more specific or more target for health policy or social science research?
Yeah, I mean, I think that the theory of planned behavior is pretty common, and that usually is used to inform the underlying mechanisms of why an implementation strategy will or won't work. right? Because it acts on theory of planned behavior, right? So we often will use those in that way. But what I think a good D&I theory model or framework should do is tell you about where you want to intervene, and how you want to intervene, and connect it to the outcomes that are implementation outcomes. And so I'm a big advocate of optimizing our theories, models, and frameworks based on what we know works in other fields. I don't have an interest, and I wrote a debate article questioning the need for more theories, models, and frameworks that are totally brand new. Because I came from a policy discipline, and when I came to D&I science, I sort of looked at the existing theories, models, and frameworks and said, what the heck are they talking about when they say broad socio-political context? Like, I don't know what that means. That doesn't mean anything to me. So I want to unpack that a little bit. Or when people just write policy, I'm like, what does policy mean? What do you mean by policy? Whose policy? What policy? Is it like a policy at the state, federal level, or is it like an organizational policy? Like, what are we talking about? And so then I looked at my sort of traditional policy frameworks from, you know, political science or public administration work. And I felt really unsatisfied by those because they teach you about, you know, a process, why something might be happening, but they don't talk about how to intervene. And implementation science is all about the intervening with an implementation strategy, right? And so sometimes I'll take in elements of those frameworks from more traditional policy fields and say, what can we learn and apply them into optimizing our D&I focused theories, models, and frameworks. So we've showed a paper about that called Where's Policy in D&I Science? And we use EPIS as the example of how to optimize it for policy work with an implementation science lens. But EPIS is not the only TMF that you could do that to. You could do it to deeper, prism, whatever, you know, is going to best answer the research question that you have.
Yeah, we have 5 more minutes before going to the others. Do you want to check if there's any other question from the?
Okay. Erika Van Dyke says 2 questions. Can you speak about the qualitative methods in your previous work? Do you use rapid qualitative analysis methods or more traditional health science qualitative methods, i.e. codebook development, 2-code analysis, etc.? And to follow up, what do journals such as implementation science look for when reviewing qualitative work? Are rapid qualitative analysis methods standard in the field? This is a great multi-part question, Erika. Thank you. So, okay, the first part is the qualitative methods. Do I use rapid qualitative analysis or more traditional health science qualitative methods? I usually do more traditional health science qualitative methods. So meaning in the analysis phase, I will use my, you know, sometimes I do deductive or framework driven analysis. So I take my guiding framework and make it do work for me, right? Because I need my framework to have a job. And I'll design a constructs for my code book based on the framework. But I also always leave room for inductive identification of new constructs to emerge from the qualitative data that I'm reading. And then I'll always use a double coder system to ensure that we're applying the code book rigorously in the same way until that might not be needed anymore. And then we can do single coding to kind of more rapidly get through the analysis phase. So I do that. I've been trained in rapid qualitative analysis methods and still sort of found, at least for me, I don't think I'm leveraging it the best way. Probably need more training on it because it still seems to take as long, or at least I have a penchant for continuing to do it in longer form. But Allison Hamilton at University of California, Los Angeles, Allison Hamilton does a lot of rapid qualitative analysis framework or rapid qualitative analysis methods workshops. And she is an implementation science researcher. So there's a ton published on rapid qualitative analysis in implementation science. And your second question was, what do journals look for when reviewing qualitative work? I don't think, so you asked if rapid qual methods are the standard in implementation science. Definitely no. I think they're acceptable, like anything when done well. So I think in my experience, journal implementation science, you know, I'm not an editor there, but I've published some qualitative work in these types of journals. And I think they want very clear methods. They want, they usually ask for a standard checklist for qualitative methods. That's becoming more and more common. But they really want you to clearly state what you did, why you did it, how you did it. And just give it the space it deserves to kind of be reflexive about your process. And then I think really clearly sort of saying what your themes are and how you got to them and supporting them with data. I don't know if there's a more specific question, but hopefully that answered it.
I have one more question. Quickly, you mentioned the journals to follow, and you mentioned a few people. For people here who are social scientists or health policy scientists, who are the people in those fields who are also implementation scientists that people should be looking for papers or publications?
The people in other fields who do implementation
Yeah.
science. Yeah, I always wonder like what makes someone an implementation scientist? I think that's kind of a fun question. I think a lot of us, say, oh yeah, I'm an implementation scientist or I do implementation science, but I'm not sure what makes someone a card carrying implementation scientist. Maybe it's all you do. It is becoming all I do, but I don't know if I identify as one. I don't know. That might be a little bit of imposter syndrome, me being like, I'm not sure what I am, or needing to put a label on it. But okay, people in other fields who use implementation science. I mean, there's so many.
I always think about Byron Powell. People at Byron
See, I
Powell.
would say Byron's such an implementation scientist. Like, I don't know where the line is, but if you're from another field or not. I think, okay, so most of us didn't come up with an implementation science degree because they just didn't exist, right? There wasn't a ton of coursework in it. And so we all came at it from different fields. I'll say this, I've always felt like a little bit of an odd duck coming at it from health policy field. And just more traditional health services research field. But I think that, and a lot of my colleagues that I talk to, like I have colleagues in social work who do this stuff. I mentioned Tanya Van Dent's work, hers is great. Byron Powell, also from social work, does this work. Andrea Eisman at Wayne State, she does really cool health economics work in implementation science, costing out some of our implementation strategies. More and more people are getting into it from different fields. And there's so much to learn about our interdisciplinary nature and really leveraging knowledge about what works in those home fields and applying it here. So yeah, there's no wrong field to come at it from. And it's just an exciting time. Like anyone could do it.
Thank you. It's
Just
yeah, good.
related to that, the field of systems engineering, is that something that you're?
Oh my
familiar
gosh,
with? And
yes.
Maybe also like the field of evaluation.
Yeah, so we just wrote, we have, through CIRC, that collaborative that I mentioned. Some really brilliant people like Cara Lewis, who's now working with the NIH, I believe. She set up the Methods Network of Expertise. And I'm part of one of the groups that looks at system science and system dynamic approaches and implementation science to uncover and test mechanisms for our implementation strategies. So that's a fun group with people from really cool systems backgrounds. Like it's led by our little team we've kind of made Bo Kim our fearless leader. She's at the VA, comes from that field, but also Anjuli Wagner comes from that space. She's at University of Washington. Gracelyn Cruden at Chestnut Health Systems does this cool work from that perspective. Andrew Quanbeck. There's a lot of cool people. Lindsay Zimmerman comes at it from a systems engineering, system science lens. Yeah. A lot of brilliant people.